Thank you. Welcome, everybody. I'm delighted to Zoom chair this session on My Way or the Highway, accessibility and responsiveness of services for vulnerable groups. A topic very close to my heart. I'm a Professor of Education and Children's Social Care in the University of Oxford. Before moving there, I worked at the Children's Commissioner's Office and the Early Intervention Foundation and the Treasury and other bits of government that I found central government loves to believe that it knows what is right for children and families of vulnerable groups, often without really defining vulnerability or really understanding the needs, issues, perspectives, and experiences of the groups that it is engaging. And that's a problem not just for central government, but for any organization that is seeking to work with vulnerable groups, with children and families. Life is complex, people are diverse and heterogeneous. And although we like to use data and science and social science to help us understand that complexity and understand need and evaluate outcomes and all the rest of it, there's quite an important distinction between people and variables. That is sometimes lost in the business of policymaking. So I'm delighted to chair this session. We've got 4 really fascinating presentations and speakers, groups of speakers who will be talking from the perspective of organizations that are trying to deliver accessibility and responsiveness of services in ways that actively engage, co-produce, support participation of the people for whom the services are ultimately intended, the ultimate beneficiaries. But it's a hard thing to achieve, to get the right mix of statistics, data, and the human and the qualitative and the experience of the individual and the wider community. So I'm really fascinated to hear what colleagues have to say. I should tell participants in this discussion, if you don't know, that this session is recorded and hopefully will be shared and the discussion will be rich and the reading of it will be useful. Please do add your comments in the chat function. Very interested to hear the views of the wider audience. Most of the discussion will be a moderated panel discussion, but I will read out comments and questions, and I'm really interested to hear what people have to say as we go through. I won't be able to read out every comment or question, but very interested to hear how people feel about this set of issues as we go through the discussion. So I'm not going to give long introductions to speakers. Each speaker is going to speak, first of all, for 5 minutes to introduce themselves, their work, and present the main ideas from the perspective of their organization. And then we'll then have a curated discussion. Again, each speaker for 5 minutes, addressing a set of questions that we've discussed in advance about how to do good voice and data work, which I'll come back to as we move to the discussion, and then a broader open discussion in which, as I say, I'd be very interested to receive questions from the audience to share with the panelists. So with no more ado, I shall kick off by asking Jen Warner and Steve Hindle from the Elton John AIDS Foundation. And I think Jen is going to speak to introduce her work and their work on this topic. Thank you very much.
Okay, so I'm Steve and I will be starting. I'm one of 2 performance managers for the Elton John AIDS Foundation Zero HIV Social Impact Bond. And I'll start by giving some context and then Jen will share the initial findings. So the issue that we're addressing is that despite a significant reduction in the number of people living with HIV who were unaware of their status, the number of new diagnoses have begun to plateau in London, leaving a significant amount of people unaware that they needed treatment. And that's a real problem for them because without treatment, HIV will attack the immune system, leaving people very compromised in terms of other infections. Looking at the London incidences, we can see that the 3 boroughs highlighted, which are Lambeth, Southwark and Lewisham, of some of the highest HIV prevalence in the country. If we're looking for people aged around 15 to 59, there are about 16 cases for every 1,000 people in Lambeth, 12 in Southwark, and 8 in Lewisham. And you can see the graph on the left-hand side showing that anything over 5 per 1,000 is considered to be extremely high. We ran a large number of focus groups, both of people living with HIV and clinicians. We piloted testing for HIV in hospital emergency departments when blood was being taken for other purposes before we started this social impact bond. And it came at a time when the foundation was exploring whether we could introduce a different way to make a systematic change to have an impact on HIV diagnosis at this time where the reduction in HIV diagnosis plateaued. And the social impact bond offered a chance to try something new, highly responsive, and to bring new money to the effort at a time when funding within hospitals and primary care was severely compromised. Next slide, please. So this is the world's first social impact bond focused on HIV, and it's specifically about bringing people living with HIV into treatment. There are 2 payment outcomes. The first is individuals who are newly diagnosed with HIV receiving their first treatment. And the second is people who are aware of their HIV positive diagnosis, but for some reason had disconnected from HIV care and are now re-engaged on HIV treatment. And you can see we've brought together a very diverse and collaborative team across the roles of outcome payers, investors, and service providers. Next slide, please. As you can see, there are a wide variety of settings for interventions. And you can see from the providers on the left-hand side of the screen that we have hospital trusts, we have primary care federations, and we also have voluntary sector providers. Thinking about how to be responsive to the needs of vulnerable people and how to increase access, the intervention settings, some are within the emergency department, which covers all of those people who come into emergency departments and need a blood test, and they're offered an HIV test on an opt-out basis. Others are around going to the GP for the first time to register, or others are about community settings where the voluntary sector have been able to reach out to those people to increase the possibility of them accessing the services. So let's hear from Lucy, who's a nurse specialist at University Hospital Lewisham, who is one of the people who is doing the emergency department testing.
We've had 41 new diagnoses and 39 of those are engaged with HIV services now. Our first new diagnosis in the department was an 85-year-old, and this was a patient who'd been seen in a number of different departments. I think it was just a fantastic reminder right at the beginning, right at the outset, that we can't make prejudgments about who may not have HIV. And it's really, I think, helped people to recognise that everybody needs to know their status. We've had 41 new diagnoses.
Thank you, and over to my colleague Jen.
Thanks so much, Steve. Yeah, as Steve said, I'm also working on the social impact bond and been really encouraged by this work. We shared Lucy's video because it introduces a difference between sharing broad demographics and sharing one individual story, which is pretty key to this discussion. We've now connected more than 200 people to HIV care. And this page that you're seeing is the aggregated demographics of those individuals. You probably can quickly identify some trends. Most common age range, 35 to 45, common ethnicity Black, common gender male. When you start to unpack those demographics though, they're much less straightforward. For one thing, the demographic trends themselves differ across service providers. So looking at ED testing, for example, you're going to see a majority of middle-aged heterosexual people. But if you look at the outcomes from one of our community groups, NAS Charity, almost all of their outcomes are Latin American men who have sex with men. There's one other really good reason to unpack heterogeneity in these outcomes data, and it relates to the case that Lucy shared, that 85-year-old who was found through ED testing. That individual was not representative of these overall demographics you can see. Less than 10% of SIB outcomes are 65 years or older. But that individual had a huge influence on how clinicians were thinking about the ED testing program. And we will come back to that later in the meat of the discussion, but it's really important to note that these individual cases can add a lot to the data itself. Next slide. Great. And I'll just wrap up with a macro view of what we've done and where we're going. The team that has been working on this is at the halfway mark of the SIB. We began in end of 2018 and will continue until the end of 2021. And these bullets in the blue box show you some of the goals and benefits from the work. The first three are all pretty immediate benefits that are already occurring. And the second two are really important because they're more long-term benefits that are important to sustained effort for the NHS and for these activities being adopted in the long term. So with that, we'll pass on to some of our other colleagues on this panel.
Thanks very much, Jen and Steve, for kicking things off so well. Next, we're going to hear from Rajneesh Ranjan Prasad from UN Women. Please tell us
Thanks
more.
a lot, Liam. Yeah, thanks a lot. And I'm Rajneesh. I'm currently working as a program specialist HIV/AIDS with the UN Women Regional Office for Asia Pacific region. And however, the abstract or the presentation which I'm making is primarily based on my work on my previous position, which was with the UNFPA in India. And in that position, I was working with especially supporting the government of Rajasthan, one of the state in India, in order to strengthen the public health system and facilitate and to reach out to the unreached population. So can we have the slides? Hi. So yeah, thanks a lot. And so this presentation is basically based upon an pilot initiative which we did in order to address the number of the vacancy in the public health system. So the challenge was Rajasthan, if you really see, if we can move to the next slide, please. It's a geographically huge state.
I didn't understand that.
And if you look, its area is almost equal to the Norway, the Poland, or Italy. It's the India's largest state in terms of the geographical area. And geography is so different and terrain is so difficult. On the western side of the state, it has a Thar desert, which is actually the world's second largest desert. And so if the population density, which is in the capital cities, around 595 person living in per square kilometer. In western part, it reaches up to 17 people living in the per square kilometer. And these districts are huge. It's like from one end to another end is around 250 to 300 kilometers. And sometimes the health service provider, or especially at the specialist level, if you're looking for the gynecologist and they may be only available at the district headquarters. So if you see, if the person in the emergency late night, they may have to end up traveling to 200 to 250 kilometers to reach out to the next facility which has the specialist available. And that's the problem. So overall state have around 40 to 50% vacancy at the specialist level and around 30% at the medical doctor level and going through. But in these districts, the vacancies goes up to 70 to 80%. So in many of the, so whether you talk about the western districts, which are the basically desert, and the southern part, which are the, basically the hilly region, as the tribal population, these were the two major areas where there's a severe shortage of the specialist level. The shortage is around 70 to 80%. The medical doctor level, the shortage was around 50%. At the nursing staff level, the shortage were around 25 to 30%. So, and some of these facilities doesn't have the service provider for almost 4 to 5 years. So considering the challenges and the difficult geographical terrain and the lack of the supportive infrastructure, state decided to take the initiative to actually provide an incentive scheme to those people or the staff who opt for going to these facilities. And so we can move to the next slide, please. When we started deliberating on the what kind of the scheme or how what should be the criteria. One of the things which state went on along with the state, we were supporting them, is to have a participatory approach. So basically a team was formed which included both the government doctors, the health department officials. It includes the officials from the UN agencies, which include UNFPA, UNICEF, and WHO, which were working over there, and some other local NGOs. So, and we have the multiple round of the discussion how to go about it. And we started with the criteria, which was around 125 to 150 odd criteria that how actually you can identify or how you can decide the incentive. But the approach we also agreed that it has to be simple. It has to be transparent. If something is very complicated, then it's going to be very difficult to implement it. So 5 criteria which we decided to use, basically one, the distance from the district headquarters, for how many years the position was vacant. What is the, it's like the distance from the nearest secondary school. What is the distance of the electricity supply and the water supply? On the basis of this, we asked the district officials to identify all the facilities on the 3 levels of the vulnerabilities, depending upon their distance and the vacancies and the status of the infrastructure. So the decision to identify the different districts under the different vulnerability criteria was taken by the district officials. So the process was totally participatory. We come up with the 4 type of categories of the incentives, which focus on the different cadre of the staff, including the nursing staff, paramedical staff, medical officers, and the specialist. And there were 3 tier of the incentives based on the vulnerability index which we developed for each facility. And it was decided also that any incentive can be only given if the staff stay at the facility headquarters and achieve at least a minimum number of OPD. Sometimes we decided to focus also on ensuring that the staff stays at the facility headquarters, because in some of the far off areas, if they live in the block or the district headquarters, the staff might take around 3 to 4 hours to reach out to their facility. They start at 6, even 6 or 7. They reach to their facility around 10 only, and they want to be back their home by 6 or 7. So they start back from their facility by 2 or 3. So they hardly there for the 4 to 5 hours. So, and in these areas, it was quite important to ensure that a staff stay at the facility, to ensure if the patient even come into the night time, they have some any kind of emergency, and the services can be provided. Next slide, please. And the initiative was initially implemented over the period of 2 years. So if you can see, and this initiative was able to make the significant difference. Also, because from the specialists, you can see the positions which are vacant around the 48%. Earlier only 48% staff were there. There 52% vacancy. It has reached up to the 67% in the especially in the medical officer. The earlier filled positions were 65%, which increased to 92%. Similarly, you can there is a significant difference, especially in terms of the paramedical staffs, in the nursing staff, the medical staff. The positions filled distance, which goes around 90%. So there is a significant increase in terms of the staff level, and then there is a 17% of the vacant position of the medical officers were filled, and then also you can see that there's a around 25% increase in the number of the OPDs, and the around 13% increase in the number of IPD. So there was a significant increase, but the challenge remains. One, the improvement was uneven. So the tribal districts, the southern part, which were in the southern part of the districts, the southern part of the states, they have seen much better improvement than the western districts, which were typically the desert districts. Second, the issues which we face also, because the payment has to be released for the district headquarter level. Sometimes there was a delay even for 6 months, 9 months by the district level officials in releasing the payment. And the third and the major issue challenge remains is like how to address the corruption. So sometimes when even the staffs are not staying at the district headquarters, they were simply sharing the 50% of their incentive with the accounts official, finance official, and the district officials, and they get the certificate that they are staying at the district headquarters and were able to get the incentives. So these were some of the major issues. Next slide, please. So after the period of 2 years, where we are able to learn that actually incentives can improve the significant recruitment and retentions, but there are limitations. As you can see, one, the number of the positions, especially at the specialist level, there is still the significant vacancies were there. So the vacancies were around 1/3 positions were still vacant even after offering the significant incentives. The second, even within those facilities, also the facilities which were far off, they have seen the less staff than the facilities which are nearer to the district headquarters or the black headquarters. Second, in order to ensure that these incentive schemes are the success, it has to be transparent and that the criteria has to be clear. So these some of the staff should not feel that they are left out or there is kind of the discrimination against them. Third, the performance indicators need to be clearly defined. It has to be simple and easily monitorable. If there will be too much difficulties, then the issues come up at the district level in terms of the releasing the payments. Some staff thinks they may have they have done their duty, but they have not got their due. Then the ownership by the local officials, which is very important, which we try to ensure right through involving them in the identification of the facility, ensuring that they are the one who monitor and release the payment. And the last thing, which any such incentive, I think, is required a very strong kind of the monitoring mechanism, especially how you try to triangulate the data which is shared by the district officials in terms of the number of staff staying at the facilities. With some kind of the community feedback mechanism is also very important to ensure the staff is really staying at the facility and they're not getting the undue benefit from it. So yeah, this was in the nutshell the scheme. Thank you. Thanks a lot, Leon.
Rajneesh, thanks very much. I look forward to asking some more questions when we get into the discussion about some of the tensions between those different objectives. It's very good to see questions coming in. Let me just say that I'm going to ask the 4 presenters to set out their stall in their initial presentations, and then I'll come back to questions of clarification. There are a few coming in. But let's hear first of all, and I'm going to distinguish questions of clarification, of which there are some. And there's also a very interesting question here from Federico Diaz about some of the challenges of objectivity in measurement that I'll come back to in the discussion when we move to that. So for the time being, we're just going to hear now from our 3rd presenter, Rob Murdoch from Bridges Outcomes Partnership, please.
Hi everyone, thank you very much. As Leo said, I'm Rob from Bridges Outcomes Partnership, and today we're going to be looking at our project Thrive in North East Lincolnshire. So if you could start the slides, that would be great. Or not. Great, and I think you can probably go to the next one. That's a good introduction slide. The Thrive project in North East Links was aimed at addressing long-term health conditions. I'm sorry, Nigel, if you can carry on clicking everything that's on that slide. Yeah, great. It's a social impact. If you can go back to the first one, that would be great. Oh, that's great. Looking at 5 long-term health conditions, which are listed here: atrial fibrillation, asthma, COPD, diabetes, and hypertension. These were chosen as the long-term health conditions that had an increasingly bigger cost for the CCG in North East Lincolnshire, and the outcomes, the impact of those treatments had not been as effective. So what we've got is a situation of an increasing cost, and the outcomes from that through the NHS, through primary and secondary care, had not had any improvement over that period of time. So part of the work that Bridges had done as part of that design was to, as part of the funding, to bring in Centre4 as our main delivery partner, and chose a number of voluntary organisations that would be responsible for curating or taking each of the different individuals on that journey in relation to their own social prescription. If you can go to the next slide, that would be great. So as part of this project was that people that get referred or come from the community that have those long-term conditions will first of all carry out a review by the link workers that are working with Centre4. that would involve a part of a well-being style that we use to look at holistically about their lifestyle, their work, and everything about their position, and then develop an action plan. And then the action plan is passed over to a tier 2 provider, a delivery organization that would help that individual in relation to their 2-year journey in relation to social prescribing. Things change, and many social organizations, charities, have been through quite a difficult period over the last few years in relation to financing and funding. And what we found from the feedback of the participants and from the data sets and from looking at outcomes was that the organizations that were supporting them on their journey really didn't offer enough of a flexible solution that met the needs of our participants. Those organizations were chosen because they were really strong in their work in community engagement. Some were great in relation to gardening, some were great in relation to mental health, employability, some really, really strong local community groups. But they themselves have been pretty handcuffed financially. And so their ability to offer what each individual needed, which was a much wider need than their traditional delivery, was really very limited. The feedback we got through the link workers that stayed with those individuals across that journey was relatively negative about the choices. So we made a decision to change, because it was more about a supply side of the organizations we'd chosen rather than understanding the demands of those participants. So we spoke to all of those tier 2 contracts, and we stopped those delivery of those contracts, which is actually a relief for both of the organizations and for our participants, because as I said, some of the stresses of some of the financial stresses and organizational ones. And what we did is we strengthened the link working team within Centre 4 and created personal budgets for each of the people on the program. And through their feedback, started a whole range of interest groups that they expressed they would like to get organized. So these groups were created. I think the first one was the women's group, then I think the second one was the fishing group, and then we went on to the sewing group. And the momentum that was created by these different groups of people interacting was extremely positive, and the ability for them to start taking responsibility for each other within those groups and then to manage budget was fantastically forceful. If you can go to the next slide, please. So what we've seen is a complete expansion of all the work that's gone across those social groups. This all started pre-COVID, which has offered amazing resilience during the COVID period. So these groups went online. They've now been driving a lot of different participants and activities. So we've had a bake-off, we've had a craft-off. Just this week, we've had the results of our Thrive in Bloom, which was sponsored by a local horticultural organization. And everything that we are doing this in relation to, online videos and everything is driven by our participants in the groups. And from that stage of establishing the groups, we transfer ownership, budget, and decision-making responsibilities over to their groups. And what we are seeing is an amazing increase in results for well-being scores, for supporting each other, and creating a truly community-led approach to social prescribing across the Northeast Links area. So much so that the GPs in that area are now asking us to set up the PCN social prescribing model based on this process that we've had before. Thank you very much. I think that's the end of the presentation.
Fantastic, Rob. Thank you very much. Very clear. And as I say, we'll come back to offer people a chance to ask any questions or clarification once we've heard from Richard Thickpenny and Thomas Dixon from ACH.
Hi everyone. Yeah, I'm Tom. I'm the research and project lead at ACH. So I work on our sort of academic and research work. I'll let Richard introduce himself as well.
I'm Richard Thickpenny. I'm Deputy CEO with ACH, and we're one of the leading integration service providers in the UK currently. And the role that I have with Tom and my team is to really challenge and unpick what integration means in terms of refugees, and then to create relevant services that meet those needs and drive them forward into society. So next slide, please. So there's a typical narrative around refugee integration of a two-way street which goes between a point A and a point B. This two-way street conversation really places a significant barrier in terms of integrations, because it's primarily focused on the acquisition of employment or English language skills and employment. What it fails typically to address is the lifespan that the refugee is likely to have in the UK, where they could be working for all of their, they could be working for the next 40 years. And also it fails to reflect our commitment to the United Nations Charter, where the refugees should not be disadvantaged in relation to the host community. And what we've been looking at is things like the expatriate services provided by big corporates, where there's a lot of work to get individuals from the UK to work in other countries. So with the corporates, they're looking at how they get their people to perform to a high level in the new host country. And there's typically a failure around that. And what we're also looking at is, well, if it's only A to B, what does that truly mean? What is the society? What has the person got to do? And what we've found is that what we have to be able to do is recognize that there is a transition from the home society to the host society, and in our case it's UK society, but also that there's a de-integration from one to the other. And if you go to the next slide, please. And this de-integration phase is a very important piece, because this is where the effects of adverse prior experience, impact on the individual, that length of time between being in the original society and adapting to the UK society, it all adds up to a sort of a level or an area where, as an organisation like ourselves, we have to consider what we do. How do we stop the individual de-integrating, and how do we move them towards the reintegration? And that point of inflection for us could be at the point when they leave the asylum process. It could be once they've left somebody's house that the individual's been sharing with. But also what you have is, what level in the previous society was that individual, and what level do we need them to arrive at in the UK? So what we often find is higher functioning professionals from, say, Syria will actually end up in a lower level stage in the UK, whereas somebody who hadn't been achieving, say, in Eritrea or Sudan, can actually access services and progress quite rapidly and move up into academic life and progress into professional work. So the point of inflection is an area that we've been looking at, and also this cycle of de-integration and reintegration. If you go on to the next slide. And what we're looking at here is, you can actually see that even in UK society, somebody could be fully functioning in the middle of UK society, a senior nurse or professional, comes to the point of retirement, and they will slowly self-isolate, become more lonely and deintegrate out from society. Those with mental health will flip in and out, depending on how their mental health impacts on themselves. Homelessness, somebody could be high functioning, a top class job in the city, divorce happens, and suddenly they lose their job, alcohol addiction takes over, they move into a state of homelessness. And again, there's a point of inflection where a reintegration phase will allow them to move into accommodation and services. And for the forced migrants that we're working with, again, that process of integration is, if we were to follow the traditional concepts where you're using the abstract to try and determine what it means, it becomes quite confusing. If you're trying to produce a service, you're trying to produce a service that moves somebody onto a two-way street against an abstract. What we needed to evidence the work that we're doing, and we need the evidence because we're working with about 2,500 people a year, and ultimately we are going for an outcomes focused social impact bond, if that's the model that we can develop. We needed to be able to evidence what was required, and a tool that allowed us to identify the services that the individual needed. So we know from that point of inflection that a lot of holistic support is required. As a person moves up towards the society, there's more career coaching required. And then to actually be at home in UK society and to get to that median position, which is the point of no disadvantage, there's a significant requirement for self-regulation in that individual. So we've got 3 significant phases of service design which have to remedy the effects of that deintegration phase and the shift from one society to another. So to be able to do that, we looked at what integration was going to mean for us, and what we saw is that it's actually the rate of change of an individual in relation to mainstream society. And by looking at it in that way, it allows us to actually adapt services quite quickly. So recently, with the pandemic, has created a step change in society. So everybody or significant parts of the population are now working from home, with developing their digital skills. Those that we're working with now have got to develop digital skills to be able to track society and move towards that. So I'll pass over to Tom now. He'll take you through our measurement tools and the services that we've been developing to go with our work.
Can we go on to the next slide, please, Nam? Yeah, so as Rich was saying, we've developed some of our own tools and services to reduce the impact of the deintegration phase and to make the refugees' integration into British society as smooth and as effective as possible. So I'll give a brief overview of some of the things on here. So we have CC, so this is a life before language learning methodology. So this basically came out of, we saw a number of our service users, a number of the refugees that we work with, being essentially trapped in something that I would call an ESOL treadmill. So they were told you can't integrate, or they were effectively being told that you cannot integrate effectively until you reach level 1 English, or until you reach level 2 English, or whatever it might be. And you're currently at entry 1. So you spend 1 year doing entry 1, 1 year doing entry 2, 1 year doing entry 3, 1 year doing level 1, at which point you're then ready to begin integrating because you're deemed to have reached a sufficient level of English. Now this was holding people back. This was, and in some cases having quite a negative impact on their mental health. So the way that our CC course works, so it's a set of learning materials along with tutor guides, which we've been using ourselves and have been being used by partner organizations as well. it provides two things. It provides upskilling for people already in the community to provide services to the other members of their community, but also crucially, in terms of what I was talking about before, it provides a set of training materials designed to be delivered in first language. So we have a number of refugee background staff members who can teach in Arabic, who can teach in Somali, and we deliver the courses in those languages so that individuals can start developing their soft skills, start developing their understanding. For example, there's a module on employment, start developing their understanding of UK employment culture and practices, so that once their English is being developed alongside that, they are then able to integrate more effectively and start that process much quicker. The second thing on there, so Integras, this is designed to measure an individual's level of integratedness, which isn't really a word, but it's a word that we use. So this is essentially a holistic assessment, which we complete with individuals when they first interact with us, and at various points along their journey with us, so that we can measure how integrated they are becoming over time in relation to the UK norm, but also essentially, crucially, we can measure the effectiveness of the various different interventions we offer and other service providers offer to see which ones are having the most impact and which ones are the most beneficial. It also provides a personal integration plan, a PIP, which directs the individual both towards services that they can be registered for directly, but also for things that they can complete themselves to develop their self-agency. So, and then again, the next one, digital coaching. Like Richard mentioned, this is become even more essential in light of what happened, obviously, with COVID, coronavirus. You know, when the pandemic hit, people in roles such as myself, I was able just to start working from home and basically carry on as normal. Whereas we saw a huge impact on not just our tenants, but the broader refugee communities in the cities we work in, where people's incomes were suddenly completely decimated. They were falling through the cracks of the various government schemes that were being offered. People who had been in the UK years and had worked for that whole time were suddenly reliant on food banks and this kind of stuff. The kind of digital skills gap was a big part of that. People weren't able to navigate into this new world of people working at home, people using Zoom as we are now, and utilizing these other digital skills in order to sort of carry on in as much as possible in the face of what was happening. So I think that the way that we do this, and broadly a broad kind of overview of all of our work, is that it's about developing the self-agency of the people that we work with. This is something that we've been very keen on for a number of years, and it comes back to if an individual's experienced trauma or experience post-traumatic stress, which a number of the people we work with have, the biggest thing that can trigger issues with that, again, is the removal of agency, the removal of choice, a feelingness of being trapped. So we do this by developing their self-agency, developing their resilience, and moving from our support model into more of a mentoring model and supporting people to be able to develop their own integration and take control of their own integration. I think we've gone over our time, so I'll stop there. Thank you.
Fantastic. Thanks very much, Tom and Richard. Fascinating, and you do a great job of reaching to the individual and the personal and the human behind the data. I'm just going to read some of the initial questions that we've had. Please do keep them coming in, but I'm just going to ask some questions of presenters, and then we'll move to the broader discussion. But some initial questions that have come in. So first of all, for Steve and Jen, Nigel was interested to hear more about how the SIB is driving engagement of people who otherwise might be missed. Would Steve or Jen like to respond on that question first of all, and then I'm going to come to Frederico's question for Rob after that.
Yeah, I'd be glad to. And I think it's related to also the way that we're influencing both clinician and individuals as well. The question that Nigel asked specifically was about driving engagement for people who might be missed. But I'd argue that it drives engagement for both people who might be missed and people who do present normal risk, what we can think of as conventional risk factors for HIV. I think about it in two ways. The first is in how we influence clinicians and improve services. So thinking back to that case of the 85-year-old who very early on in the program was identified through ED testing. This became culturally emblematic for the program. Clinicians really were quite interested in this patient's case because of the patient's age and the lack of risk factors. So people really were starting to internalize the understanding that people who were not considered high risk really could have HIV. Clinicians shouldn't be making assumptions about who does or does not need to be tested. And this kind of storytelling about one anomalous outcome really drove higher testing numbers, especially towards the beginning, right when that story kind of broke in the hospital. These stories are breaking down stigma as well, and helping to ensure that everyone in the high prevalence borough is treated the same. One other example I'd give from a different provider is the GP federations, which are an alliance of quite a number of individual practices, have started using their weekly newsletters to emphasize specific cases of individuals who are found through this. So it's not going out every week, but every so often they're saying to the other practices that might not have had a case come through, hey, this is the case that we came through. They anonymize all the data, but they say, this is the person, this is the demographics of the individual person that we found. And that's really, really elevating the individual story, and that's what can reach clinicians. Separately, I think there's a really important link to reducing stigma and influencing the broader culture. The obvious case is going to be a heterosexual older person who hears about that case and says, oh, maybe I do apply. But the less obvious case, and I would argue that just as important, is the cultural and psychological impact of this. While HIV stigma has decreased over the past couple of decades, there's still very real and prevalent stigma. And we know that stigma can paralyze people who have experienced significant discrimination or who have strongly held beliefs about what sexual identities are acceptable, what behaviors are acceptable. When we're elevating much more diverse stories of what it means to have HIV, what a person can look like who isn't high risk, this is promoting a narrative that HIV is just like any other condition, which it is. And it is pushing people across a high prevalence area to be tested. And that broader cultural reason is why we started elevating some of these stories on social media, and we'll continue to consider that. The third and related one that I won't get too far into, but I see that Ruby Dickinson started to raise it in her question, is I also would argue that there's a really interesting influence to policymakers, because our really flexible commissioning model here is valuing everyone equally. So it's allowing you to tailor to the individual and get that person to care. But it's also able to elevate an individual story and highlight someone to policymakers that might not normally get airtime on that.
Thank you, Jen. As I say, I'm going to go to Rob now to ask Frederico's question, and then after that, I'm going to ask Rajneesh the question from Nigel, just to give you advance warning, Rajneesh. So Frederico Diaz from the CIBS Chilean government has asked the question, very interesting. One of the main questionings, one of the main issues about involving users' voice on metrics is that measurement is not objective and could undermine investors' interest in CIBS. How do you reduce that risk when there isn't a large pool of investors? Rob, I wonder if you might answer that question, as Lee has suggested, from the perspective of an investor.
I'll do my best to try to answer that question, but it is a really complex one. I think the place to start is that as a social impact bond, the metrics that we look at in relation to impact are fixed. So if you look at the project that we talked about, Thrive in North East Lincolnshire, what is the issue? The issue is an increase in long-term health conditions and increasing demand but not less effectiveness at treating those and higher costs. So the impact measurements we will have in that model are uses of primary and secondary care by all of those involved in the project, frequency, duration over that period, and also maybe a more subjective measurement is the well-being staff for each of the individuals that participate. So in that way, our fixed metrics do not change. What has to change though, over that period of time is how you use user voice to improve the delivery of meeting those objectives. So if you don't take into consideration and increase participation of those who stop doing things to people, but getting them involved in the design of that service, you can measure the impact, which we talked about, is to reduce frequency of use and to make sure that people manage their long-term conditions much more effectively. So I don't see there is a stress between those different elements. Your impact measurements, your accountability it remains the same over that duration. That's the challenge. That's what you need to measure. But what needs to be flexible is how you personalize those services and you learn. And so from an investor perspective, better returns on investment, far more effective in relation to achieving those goals. The metrics don't change, but what does change is how we meet the needs and discover things. One thing that's consistent for me, which has come out of this, is that we talk a lot about behavior change, and we talk a lot about behavior change in relation to the participant groups. However, equally important when we look at these projects is behavior change of all stakeholders. So for example, the delivery organization, are they really utilizing different techniques about user engagement? The funding organizations and the investors, are they looking for, why are they there and what are they trying to do? Do they want to see a fixed model? And the partners that we have, such as the CCG, the GPs, the primary care, the secondary care, are they changing their behavior in relation to how they refer people onto the program and how they are treating people? So behavior change comes to the investors, to the delivery organizations, and to all those involved, not just the participants. And if you embrace that change, keep the metrics the same, but you'll start to discover there is a far more effective way of designing that journey for each of the participants by giving away some control.
Rob, thank you very much. Very interesting reflections. I don't know if Federico would like to respond. Don't do so immediately, but do please type, Federico, if you'd like to come into the discussion later to pick up anything in Rob's answer. I'm just going to ask one question for Rajneesh, and then I'm going to move to the discussion of our core questions, asking panelists for a further 5 minutes on our core questions, which I'll read out. But before I do that, Rajneesh, interesting question here from Nigel Ball from the Go Lab about the tension between the value of incentives, which increase access for service users because the intrinsic motivation of staff was not sufficient. It needed the incentives, it seems, but it opens an opportunity for corruption. And I wondered if you could give us a minute on just 1 minute on the tension between those things and how you manage that, please.
Actually, that's a very interesting question, and probably the 1 minute will not do justice with this, because that goes to the next level of how the challenges not only the country like India, many other developing countries face, where actually health is a political subject, and how the appointments for the health staff or their postings takes place is mostly the political decision. So in absence of a proper HR policy, many of the staffs who goes to such facilities, part of facilities, they consider as a kind of the punishment posting, because you are not able to have the sufficient influence with your political masters or the officials that you are able to get good posting. So in that kind of the condition, ensuring that intrinsic motivation remains a challenge. If there is a proper policy in order to ensure that some of this part of posting, if they consider additional weightage for the promotion or the other thing, maybe the staffs maybe more motivated. But it doesn't take place, and it even so in absence of that, and if you consider this kind of the punishment postings, so maintaining that intrinsic motivation becomes very difficult. The hard incentives, though, provide scope for corruption, agreed, but at the same time you also see kind of the improvements. So sometimes this improvements is also measured in terms of the number of the deliveries which are taking place, and that's why some of those criteria try to be put in, that at least minimum number of OPD has to be taken place. Then the incentives were also based on the increase in the number of deliveries taking place in those facilities. So we try to ensure if there is an increase in the number of the deliveries, so at least it means now the community is going over there because somebody is there to provide the services. So there is a scope for the corruption, but in absence of the other methods where we can ensure the proper intrinsic motivation, either through offering them the promotion, increased weightage toward the promotion, or sending them for the training. When those things are not there, then probably ensuring the hard cash remains a major way to ensure the service delivery in such kind of the condition. Yeah, and that's also the issues related with the decentralization. When we talk about the decentralization, it's very challenging because the community is also not homogeneous. When the political master changes, they try to get someone who is essentially from either from their community, they close to them, get them the good postings over there to maintain, and then the other staff who doesn't, they feel kind of the left out or punished. So how to measure that? Thank you.
Thank you. Difficult. Lots of great comments coming in. I'm afraid I've let time get away with us, so I'm going to go to our speakers for 5 minutes each. And please do stick to the 5. I didn't ask Richard and Tom a question, so I'm going to ask you to go first by way of recompense. Let me just say, as Lee has sent out the message as well, we asked speakers to reflect on 4 questions, and they're going to pick up whichever of the questions they most want to. Please do keep your comments coming in as they go through, and speakers do feel free to respond to other speakers in your comments. Don't just read out a lecture. The general issues that we've asked you to reflect on are: how do you ensure that community and practice voices are heard with real impact? How do you ensure voices are representative of wider populations? There's always the issue that we hear from some people, and others are excluded. How do you work with voice alongside statistical data? We've already had some interesting discussion of that. And also of the challenge, can single outcome indicators capture the multidimensionality of real lives? And I guess the way I phrased the question there indicates that the answer is probably no. But very interested to hear speakers' views in relation to whatever from that they would like to pick up. And I'm going to start, if that's okay, Richard and Tom, who's going to go from your duo? Richard, thank you.
Yep. Yeah, just looking at around the single outcome indicators and the voice. So what we were finding actually is the voice of the refugee had actually disappeared because there was always the view that refugees are a homogenous group of individuals. So therefore, all services were targeted on essentially employability. There's a dialogue around getting refugees into work so they can pay back to society or contribute to society, which we saw was ultimately leading to individuals being put into national minimum wage employment as the sort of best option sort of thing. So we did an initial work around social return on investment, where we saw we were getting a lot of people into employment and therefore thought that we were doing a really great job. But then when you actually look at the 40-year working lifespan of an individual and see data that says that 75% of refugees who go into national minimum wage jobs stay there for the rest of their working lives, you could actually see that there's about a £400,000 difference in lifetime earnings between the refugee going through a service into employability programs and the mainstream society. So what we needed was something to actually unpick the integration component, and that's why we've created the measure of integratedness. So that that is a multi-dimensional measure. It looks at health and well-being, looks at digital skills, financial management skills, looks at social networks, and that. So it actually looks at the ability of the individual to be able to progress an integration journey. So in building it, we've tested it as an organization. We work with about 700 refugees every year, and these are spontaneous arrival refugees as opposed to those coming through the main Syrian resettlement program, who we deal with on a different level of work. So we actually have every year 700 people who are going from a point of being vulnerable and homeless and newly arrived through to progressing into a state of independence. So we needed a measure so that if we're looking at social impact bonds and outcome bonds, to be able to go to an investor and say that we were improving, of making an impact on the ability of a person to integrate into UK society, we needed to have that measure. And integratedness, we will continue to work on it, and we'll work with universities to fine tune how that measure can be truly multi-dimensional. But what we've done is UK policy with the Home Office measures of integration can measure at the population level integration and go that 67% of the population has a language skill, that type of measure. And therefore there's a two-way street. What we have created with the level of integratedness is what it feels like from the personal level, and use that as an indicator then to trigger the types of services that actually allow an individual to go from their house down the garden path and actually try and find that two-way street to go forward. So it's a very complex piece of work. Myself and Tom have been researching around it for the last 3 years. Partnered up with 3 universities in various ways and a number of Erasmus projects to make it happen. So you can use a measure, but it's that key. It is that thing. It's an indicator, not a definition of the individual.
And Richard, can I ask you to reflect on the tension between what you've said about the challenge of linking average aggregate statistical data with the sort of more complex and longitudinal diverse pathways of individuals in a world in which a SIB model is the useful investment model? Is there a tension between those things, or have you found a way through that?
I think as we've got the model working now, we can go through it because we understand that there's a de-integration phase, there's a point of inflection, and then there's an integration phase. We know the components that are required to progress that along. So Tom went through the work we've done with CC. So there's a set of training that each stage progresses, and using the Integras tool, which is a really quick and easy tool for frontline staff, we can actually track data longitudinally to show that there's a difference being made. But importantly, what it brings out is key things like the effect of prior education. So higher educational levels prior to arrival in the UK usually result in a lower dip and a smoother integration journey. Those who've got less than secondary qualifications immediately come into a very competitive workspace for entry-level jobs. They're disadvantaged because they have the refugee label. And if you just look at that, then what you end up with is those individuals only ever go into precarious employment. By using the data and analysing the data, and we've been able to identify some of the key areas that hinder somebody's progression. And we've got the services then to actually impact. So when we do go to an investor, we can actually say these are the steps and show that there's a progression going forward. So the tension has actually helped us develop a better system, because prior to that, it would have only been ESOL followed by employability. And as Tom says, that tends to trap people into a cycle of low-level job, precarious unemployment, and no progression. So as we've gone through, we've got more evidence that says that actually, if you take these steps, then a person can progress better. So we'll be able to take those for, to an investor and show that there is an outcome that's happening.
Fantastic. Sounds like you've achieved a synthesis between the different sources of information, which for those of us doing mixed methods is always very hard. And the Intergrass tool seems like quite an interesting thing. There's some discussion in the chat that about what can be shared there, but I'll let Lee perhaps summarize that at the end. Let me go again, staying in reverse order. I'm going to go to Rob now. Rob, what would you like to pick up in the discussion?
I'll just reflect, if that's okay, on some of the things that have emerged, because obviously remembering all of those points is quite hard. There's been a bit of discussion about voice. I suppose my thoughts on social impact bonds and other kinds of financing are available, absolutely. But it's how, and I'd support all of those, but it's how we bring that flexibility, that collaboration, and that accountability into the model. The way I like to think of it, when you use social impact bond, social has to be the community and absolutely the voice of the participant. So that's really important. Impact, we've already discussed on that you do need very clear metrics. So in North East Lincolnshire, we're looking at usage of primary care, secondary care by those involved in the group, reductions in those numbers, and improvements in how they believe they're managing their own condition. So the social is the voice, the impact is the metrics, and that bond is trust. Trust with your investors, trust with your participants. And those three things, I think, underline why you would have a social impact bond. So voice is critical in that area. I think that it has to be a learning process in delivery. It's quite difficult to do that in a traditional type of contract. And that's why the trust part is really important, that your board members and your governors can look at the transparency of the data and can respond quickly and effectively to increase the efficiency and the improvement of what you're doing. And that will not mostly, I think, always involve the voice of the participants. We sometimes get scared, there's large amounts of money here, and do we really trust, it comes back to that, do we really trust participants? Should we just give them all the money and allow them, you could take it to one length, give them all the money instead of involving different organizations and allow them to spend that money as they see more wisely. But you have to get the balance right, as it goes back to that accountability. Where does that money go and what impact have you made? So it's the journey. So for my perspective is you can't have a social impact bond without voice, hard metrics, and the right kind of accountability and trust between the social investors and those participating on the program. It's very difficult to give away control and give away power, but it's essential to do it, because otherwise all you're imposing is your view on what can be effective. And what we do know in these changing times is by doing the same thing again, it's not going to work. So start to trust your participants, start to empower them by giving them the tools in order to manage their own groups, and then maybe introduce managing their own budgets, and then give them the idea of how they can spend it and the training that can help into empowering them to do things. So for me, social impact bond is voice, metrics, and trust.
Thanks very much, Rob. And just picking up Ruby Dixon's question earlier, I mean, I totally appreciate what you say about trust and voice together with impact metrics all being important. Is there something specific about social impact bonds that makes voice more relevant and important and recognized than it is in the context of other financing models?
Well, I haven't got the whole panoply of different financing models around. So, you know, and of course, you know, we're all biased about different things, but I've had a experience of delivering contracts internationally for the last, you know, 20 years. One of the differences with social impact bonds, and it comes to that trust and governance element, is it's very hard to turn around a government type of contract or a contract even at local level without understanding the inputs and the outputs. So what happens traditionally is the finance can be put around, we've got problem X over there, we think input Y is going to work, and so we're going to commission it to do that. That doesn't create a relationship that is based on the quality of insight from the voice. That's based on a lot of, you know, supply side elements in order to address that problem, rather than understanding the local differences that you have. All of the people that participate on our program, they come and they're seen as a deficit. They're seen as a problem. You know, they've got a long-term condition. That's the uniqueness of where they come. Our job is to turn that into their assets. What of the strengths do they have in order to support not being seen as a deficit, but as being seen as a real strength in that community? And so I think SIBs in many ways have a unique perspective and flexibility that drives collaboration and it drives accountability just as much. So don't get me wrong, we're not all hugging clouds. Every month we have our numbers, we have our metrics, we have to do it, but we reflect on, is this the best way to do it? And how can we get more people from the community involved in the delivery of that and give away ownership?
Thank you very much. I'm going to go next to Rajneesh, and then I will come to Jen. Rajneesh, what would you like to say in relation to this discussion?
Thanks, Leon. I will broadly also want to talk a little bit about the wider participation, or how we can use the voices along with the statistical data. And I will take it from what Rob said, especially about the voices, metrics, and trust. And I will say, when we're talking about the wider population, probably we need inclusion, platforms, and civil society, or a kind of the facilitator sometimes. Because the challenge is, when we're doing it, one, community is not a homogeneous groups. So you need to provide the platform at the various levels. So some of the things which we try to do at the state level where we're previously working, one, having a kind of the community consultation at the state level. Then at the each facility level, the community groups were formed. Third, during this local Gram Sabhas, or where actually the local democracy takes place, the health is supposed to be an agenda to discuss among the villagers every month. Here, so you try to provide a kind of the platform where the people come together. You make the participation of the district or the block officials compulsory in those platforms to ensure that they are also there. So whenever the feedback is provided, that is taken back and the actions can be taken. Third, to deliberately try to ensure that there is a kind of the inclusion. So you look at whatever the different kind of communities are present over there and how many the community representatives are there. So each group, the community monitoring group, has to be ensured the presentation among the different groups. And finally, one thing is, like, despite of all these attempts, there are the people who are among the poor. Also, there are the people who are more poorer, who are living at the margin. They doesn't actually come on those platforms. So you need to ensure a kind of either a third-party civil society or a facilitator has to be there who can provide through them. You can support them to ensure that their voices and the participation in those platforms. So this is something which you try to do, and ensuring that the kind of the community monitoring mechanism is there, which provide the feedback to you on the regular basis, and these feedbacks are taken during the different meetings, and then this share with both the officials and the third-party agencies. And there, in this area, where the role of the other organizations, which include the UN agencies, other NGOs, becomes very critical, because whenever we are also the field visiting, we try to make sure that we visit those who are the poorest of those, who are the farthest from these facilities, and then try to bring those voices back to the state, because we have our own access to the senior official directly. So you can provide them the input, because those people who are actually they are also afraid at times of sharing their voices. they are fearful that some kind of the actions may be taken by the government officials who are, because these are the official health service providers with whom they negotiate or they talk on the regular basis. You will come and go back, you will visit over there for a day and then you will come back, but how do you show? And that's why having a presence of the local civil society at times also become a kind of the very important to ensure that they have a kind of the confidence that no action will be taken. I think that's yeah. Thank you.
Thank you, Rajneesh. Can I ask you just another minute on the issue of inclusion? You talk about the challenge of reaching the poorest, and communities, even poor communities, both include and exclude. And I wonder the degree to which you feel in the work it has been possible to reach beyond those who are included in communities, and how you've done that. Just in a minute, what's been successful in reaching as far as possible?
There are two things. One, you have to do kind of the mapping in the different geographical area which are the most poorest. The second, you'll have to ensure in all those platforms where you provide, like we have the community group at the village level, so to ensure the kind of the reservation for them. At least 2 people from those communities has to represent it. Third, especially among the district also, there are the particular areas where this community lives. So you work with the civil society organization to reach out to those communities and to ensure that their participation and some kind of the wider capacity building program has to be implemented. They have to be also taught that those services are their right. If somebody is not providing them, is not doing a kind of favor to them, is their right and it's provided by the government, and it's their need. And if they want to access it, they have to raise their voices and their concerns. So trying to ensure that through those civil society organizations that they participate in these platforms, you ensure the reservation in those platforms that at least 2 or 3 people from those communities are there.
Fantastic. Thank you very much, Rajneesh. I'm going to turn now to, I think, Jen from Elton John AIDS Foundation. Final speaker. You have the opportunity, Jen, to offer us your comments on these questions or take us in a different direction as you see fit.
I'll actually pass to my colleague, Steve, to start off, and maybe I can give kind of a wrap-up thought after.
Of course. Sorry. Steve.
Okay. I've been really interested to hear the different conversations about voice and the different ways that people have thought about voice and the interactions. One of the interesting things about SIBS is the laser-like focus on outcomes and the ability of providers to be able to flex and adapt their service, both in response to understanding what works for them, but also in terms of feedback from users of their services. One way that this has played out within our SIB has been about the testing of people who are having attendance at emergency departments on an opt-out basis. And it is a very different thing for a clinician to say to somebody, in this place, we test everybody for HIV if you're having a blood sample taken, unless you tell us differently. And the difference between saying that and saying, would you like an HIV test because we're taking your blood, is a huge difference, both in terms of the provider, the clinician, and their level of comfort about asking, do you want to take an HIV test, which may open up all sorts of questions in the mind of the user. Why are you asking me? What assumptions are you making about me and my lifestyle? But it's also in terms of the clinician's ability to say, I feel comfortable saying this because it's an exceptional thing. Do you want to be an exception to our usual practice? And the interesting thing is that as this is happening in emergency departments, the users are coming back to say, I wouldn't have felt okay if you'd asked me if I wanted a test, but actually I feel very okay because I understand that everybody has this test. And this interaction gives positives on both sides. I really liked the points that Rob was making about trust. I think there is trust between the investors and the providers, but there's also that interaction between providers and the trust between providers. And this laser-like focus on the outcomes has enabled us to build up trust between the hospital providers and the primary care providers. As you might know, there is not necessarily as an effective exchange of information about patients between hospitals and primary care as perhaps one might like. But the ability of this SIG to bring people together to say these are the outcomes that we're focusing on has really enabled local clinicians to be able to work with other clinicians, although they're in different settings, to be able to work more effectively for the benefit of the person. And that really has made a great deal of difference to it. The other part of it is when we talk about primary care and we talk about emergency departments, we're talking about universal. This is going to happen across every person who comes in. When we look at the voluntary sector providers, we then get the real benefit of working with local organisations who know their constituents really well, and they can reach out and those voices can come back. And again, we've heard this kind of two-way interaction between the organisations making services available and then the interactions with the people in the community who are saying, well, actually, this wouldn't work for me. You know, don't send me an at-home testing kit to my address, send it somewhere else and I will pick it up. Send it to one of these kind of mail drop type services and I'll go and pick it up because I don't want anybody in my household to understand what this brown package is. They might ask me questions. So the ability to have that two-way interaction has been really effective. Jen, I'll pass to you for any closing comments.
Thanks, Steve. I would just end kind of by reflecting on the question around, are we really able to use data, use stories to bring across the multidimensionality and complexity of the humans that we're reaching? I think, Leon, you're right in stating that kind of even the way that the question's structured, the answer is obviously no. But I would also say that I think it's okay as long as we're really clear on what goals we are trying to achieve. I think it's really interesting how in some of the different cases that we've shared, there have been different incentives and different reasons to either share data or to share anomalous patient stories or to share more indicative or majority patient stories. There could be a variety of different reasons. With Steve and my work on HIV is a disease where kind of the majority case and risk factors might be more well known from the start. And what we're really trying to change in terms of tactical behavioral change is increase the uptake of services. And so elevating anomalous stories has been really helpful in that and saying, look, anyone can get this disease. At the same time, I can see where saying anyone can come access these work services might not be the correct and most helpful way to improve access to a really tailored, more patient-driven interaction, or perhaps something that needs more individualization. So I would anchor for that reason on what are the goals we're trying to achieve and really considering the data and the patient stories as ways that we can get closer to those goals, and really making sure that while we do that, we keep the patient's interests at top of mind and keep patient, and also something that hasn't come up a ton, but I've seen come up in the chat is be able to balance really rich stories with patient confidentiality, which is obviously just an ongoing challenge and another really important tension to balance as we bring these things across. But I would wager that it's very important tensions and challenges to be balancing because they get us to the best answer and they're the most likely chance we have to really get these behavioral changes because this work is about the people.
Thank you, Jen. And Steve, very much. Very interesting final reflections. I'm going to go to Lee to see if Lee would like to introduce any other final remarks or comments from the chat. Lee, is there anything you'd like to add before I conclude? I'm speaking very slowly.
No, nothing to add from from the chat, from what I can see. I just want to thank everyone for a rich and interesting discussion. I know we say this at every session that we do in our conference, but sometimes user voice being at the forefront sometimes feels like a fringe topic at some of these conferences. So I'm really pleased that we came together today to have this really interesting discussion, and I hope we can continue it.
Fantastic. Thank you, Lee. Let me add my thanks to you for your very careful and effective organization of this session. I'd like to thank the speakers. We've heard 4 very interesting presentations around some very different topics: HIV clinics, refugee support, recruitment to health services in rural and indeed urban Rajasthan, and social prescribing in Northeast Links and elsewhere. You know, some very different topics and places, but a general theme, I think, very clear about that. For me, that this tension between the need to have aggregate statistical data, which you see very clearly for funders and governments to know that they can have confidence that things have aggregate effects, that might translate into benefits that can be costed or can be understood, at least quantitatively, in terms of outcomes that people understand on the one hand, and the incredible diversity and complexity of people's lives on the other. I thought Richard and Tom particularly emphasized that in their presentation, and that's very rich for me, that distinction between the diverse pathways of refugees as people going through their life, and then the need to have very single unidimensional indicators in order to think about aggregate success. That is a very big challenge. I don't say that we've solved it here, but I think there's something very important about synthesis, about the idea captured by Rob with his phrase, which I shall borrow and use, voice, metrics, and trust. We sit at this moment in the United Kingdom, where, as I understand it, the number 10 Downing Street, the very center of government, has recruited a data scientist. And there is this idea that in the very center of government, you can monitor aggregate data sufficiently well to know what works, and you can pull levers in Whitehall. I think this discussion has shown that the real work of trying to understand and influence lives and behavior requires very rich, detailed understanding of people, and that includes qualitative as well as quantitative information. And that is a major theme for me. And it's been very rich and interesting to hear that come through in the context of a conversation about a particular funding model. So lastly, I want to thank participants. There have been some great comments and questions in the chat. Thank you for your attention. Thank you for joining this session. And with that, I shall close, and I hope you enjoy the rest of the conference. Thank you. It's been a very rich discussion.